Hello, my name is Dr. Roger Henderson, and I'm a GP in South West Scotland, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. It really does help. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. And you can also visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings which occur all year round. Now, in this episode, I thought I would discuss syphilis, mainly because the UK British Association for Sexual Health and HIV, better known as BASH UK, have published updated 2024 guidelines with recommendations on the diagnostic tests, treatment regimes, and health promotion principles needed for the effective management of syphilis. So this podcast is basically going to be an overview of syphilis, and I'm going to highlight some of the key recommendations of the new BASH guidelines. Now, as we know, syphilis is caused by infection with the spirochete Treponema pallidum and is transmitted by direct contact with an infectious lesion or by mother-to-child transmission via the placenta during pregnancy. Now, about 1 in 3 sexual contacts of individuals with infectious syphilis will subsequently develop the disease, and there are over 10 million cases of syphilis worldwide each year. Following a temporary decline in diagnosis in the UK, which corresponded to reduced testing during COVID, diagnoses of syphilis have rebounded in 2023 to over 9,500. And as we know, it's a multi-stage, multi-system disease, broadly defined as acquired or congenital. And we can categorize it as early or primary, secondary, and late or tertiary, with a latent stage following secondary syphilis. So if we look at acquired syphilis in these stages, then primary syphilis is a local infection with a typical incubation period of 2 to 3 weeks, although the range can be longer. Secondary syphilis is generalized infection with a slightly longer incubation period of 6 to 12 weeks, typically with a range of up to 6 months. Now, following secondary syphilis, there's a latent stage. Early latent syphilis is asymptomatic syphilis that lasts less than 2 years, and late latent syphilis is asymptomatic syphilis for greater than 2 years. At some point, we then may develop tertiary or late symptomatic syphilis, and we can split this into cardiovascular, neurosyphilis, and gummatous syphilis. If we briefly mention congenital syphilis, this obviously causes problems such as miscarriage, stillbirth, prematurity, and infant death, and early congenital syphilis occurs in the first 2 years of life, with late congenital syphilis occurring after that. So just going through the stages in a little bit more detail, primary syphilis occurs following intimate contact, and the Treponema pallidum enters through the mucosal surface or abraded skin and then produces the classical chancre or ulcer of primary disease with an incubation period of 7 to 21 days. Higher infectious doses cause the ulcers to develop faster. If we see a solitary, painless genital ulcer, then this strongly suggests a diagnosis of primary syphilis, although the problem here is this might not be noticed by either patient or doctor and then heals spontaneously. At this time, you might also get discrete painless lymphadenopathy and sometimes mouth ulcers, and co-infection with HIV at this point may result in multiple ulcers. Now, if the primary chancre is left untreated, then about 25% of patients will then go on to develop signs of secondary syphilis about 3 to 10 weeks after the appearance of the initial ulcer. So, the clinical features of secondary syphilis is typically a widespread rash and generalized lymphadenopathy. Now, that rash is often maculopapular, macular, and occasionally ulceronodular, but is non-itchy. Neurosyphilis can occur at any stage of the infection, and about 10% of patients with untreated syphilis will develop this. And secondary syphilis might also go on to develop more generalized problems such as hepatitis, splenomegaly, glomerulonephritis, and even pulmonary, bone, or gastric involvement. Now, about 25% of people who have untreated secondary syphilis will then go on to develop relapsing episodes where symptoms include a rash and a fever. But secondary syphilis typically resolves spontaneously within 3 to 12 weeks, and the disease then enters its asymptomatic latent stage. Now, the latent stage is defined as early within 2 years and late after that time, and that then ends with the development of tertiary disease. Now, you might think that's a slightly arbitrary distinction, but it is important because about 25% of untreated patients develop secondary disease recurring during the latent stage. Now, tertiary syphilis develops in about 40% of patients with untreated syphilis, typically many years after the initial infection has occurred. And this is characterized by often severe end organ complications. And we can divide this into gummatous, cardiovascular, and late neurological disease. But the clinical manifestations are highly variable. Congenital syphilis occurs when the fetus acquires the infection via the placenta from the mother. And if we're considering a diagnosis of congenital syphilis, then we need to consider factors such as the mother having syphilis, the adequacy of any maternal treatment, and the evidence of syphilis in the infant. Now, most clinical signs of congenital syphilis aren't visible at birth, but usually will develop during 3 months. Now, what about investigating syphilis? Well, as a general point, investigation should always include a screen for all sexually transmitted infections, including HIV. And the most commonly used method for diagnosing syphilis is serological testing. So we should be performing this in all patients with signs or symptoms of syphilis. Now, serology testing requires the use of both specific treponemal tests and non-specific non-treponemal tests. So the usual approach here is a treponemal test as the initial serological test, followed by a non-treponemal test if that treponemal test is positive. So the treponemal tests include the treponemal enzyme immunoassay, the treponemal hemagglutination assay, the fluorescent antibody absorption, and the immunocapture assay. We used to use a Treponema pallidum particle agglutination, or TPPA assay, but this was withdrawn from the UK in 2022. Now, if we then develop a positive treponemal test, we then go on to a non-treponemal test to confirm the diagnosis or to provide evidence of active disease or reinfection. And non-treponemal tests include a RPR test and a VDRL test. Now, it's important to remember here that treponemal specific tests remain active lifelong and so are unable to differentiate between active and past infections or monitor response to treatment. So this does mean we have to inform our patients that any future treponemal specific testing will show previously treated syphilis infections. Now, BASH recommend there should now be expanded use of PCR testing. There should be an update to serology testing in light of withdrawal of the TPPA from the UK. That positive screening test should be confirmed with a different treponemal test and a second specimen for confirmatory testing obtained, and an EIA or CLIA detecting both IgM and IgG is probably now the screening test of choice. They also recommend that routine syphilis serological screening for people living with HIV should be recommended at 6 monthly intervals. So let's turn to treatment, and this should usually be within a sexual health clinic with inquiries about sexual contacts being routine. But the good news is that the treatment of syphilis infection is curative with appropriate antibiotics, but obviously prompt diagnosis is vital because of the risk of the long-term complications we've already heard about. Now, parenteral benzyl penicillin is the first-line drug treatment for all stages of syphilis, with the dose and the length of treatment being determined by the stage and clinical manifestations of the disease. BASH now recommend that administration of benzathine penicillin with lidocaine is the recommended option and is now licensed, and that macrolides are no longer an option for treatment because of antimicrobial resistance. Ceftriaxone is an alternative treatment and is appropriate in most cases where penicillin can't be used. Now, obviously, when we're using antibiotics in syphilis, we've always got to remember the Jarisch-Herxheimer reaction is a possible effect. This is an acute febrile illness with rash and headache, myalgia, chills and rigors, but it typically resolves within 24 hours and does not require cessation of antibiotic treatment in most cases. So, BASH recommend that we should advise our patients about any possible reactions to treatment and to observe for immediate reactions to treatment, and that steroid therapy is now recommended when managing neurological or cardiovascular syphilis to prevent potentially serious consequences of the Jarisch-Herxheimer reaction. And in those who do report allergy, we should be considering skin testing and subsequent penicillin desensitization and treatment. Now, with follow-up, the purpose here is to identify reinfection and to document effective treatment and partner notification, but it may take a number of months for the non-treponemal titers to drop fourfold following treatment, particularly following treatment of reinfection. A sustained fourfold or greater increase in RPR titers does suggest reinfection or treatment failure. And when we talk about treatment failure, this is characterized by the fourfold or greater increase in non-treponemal test titers, recurrence of signs or symptoms, and other reinfection has been excluded. Any reinfection that may occur should obviously always be retreated, with sexual partners being screened and epidemiological treatments considered. So, I do hope you found that quick overview on syphilis helpful, but do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But as always, thank you for listening, and until the next time, goodbye.